Okay, it's 10:30. I will call a meeting of the neighbors of Dunn County to order. It's January 20th, 2022. Roll call. All are present with the exception of Supervisor McCulloch, which I'm sure he's in the sun by now. Approval of the minutes. We all should have had a chance to read them. Is there a motion to approve? Motion by Supervisor Jensen, seconded by Supervisor Cna. Are there any questions? In hearing none, all those in favor of approving the minutes say aye.
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 Opposed? Carried. Krista, do we have any public comment?
No public comment.
Okay, thank you. We'll go right into Administrator Meyer's report.
All right, thank you, Chairman. So first of all, as always, Quality Assurance Steering Committee updates. So this month we did go over our quality metrics reports, as well as our usual reports, which there was nothing that was completely alarming. The only thing that kind of stood out that was different from normal was we did have a significant increase in falls in the central building. We did look at all of those. There was no trend in shift or reason or things like that. It did show up a little bit higher as it is all by percentages, which the central building currently only has 15 residents. So a couple falls adds up to a lot higher percentage in a smaller building or a less census in a building. So due to having the two households closed and only having 15 residents in central, all of those metrics, having one or two people that meets any of those quality indicators throws the percentage off significantly. But there was no concerning situations through any of that. We also went over the safety committee report, which the safety committee went over our most recent survey. That was the life safety code federal survey that we had talked about last month in this meeting. And we went over that and the plan of corrections for that as well. Any questions for Quality Assurance Steering Committee?
I have one comment. You said falls and not calls, right?
Falls, yep.
Yeah,
So
okay.
resident falls.
Okay.
Any other questions? All right, and we'll go into the employment activity report with Chris.
Morning, everybody.
Morning.
So for the December employment report, we had listed the interview scheduled. We had 11 scheduled. We had held 9 interviews. A new thing I've done is in red, I've kind of started putting what was scheduled for in-house and what was scheduled for agency staff. So, so we had 11 total scheduled. We had 7 of those were agency. Number of interviews held were 9. We had 2 no-show and 7 of them were agency. Number of positions offered were 2. The hiring for December is a little bit off because a lot of the interviews were end of November interviews, kind of coming in with a December hire date. So positions accepted and hires for December were 8. We only offered or only had to do 1 above a step 3, and that was for a full-time AM cook position. Wanted a little bit more money. If we go down to resignation reasons, we did have 12 resignations. They're listed there. Just, not enough hours available or too much with other job. We had a couple of part-time CNAs that just stopped showing up or kind of disappeared. Part-time CNA wanted something outside of healthcare. We had a full-time CNA resign because of the impending vaccine mandate. We had a CNA, a couple of full-time CNAs retired early, or one retired early, resigned. One full-time CNA was offered more money at ALH. We had a full-time RN retire, and then we lost 3 homemakers. 2 of them just kind of disappeared, stopped coming to work, and then 1 took employment outside of healthcare. We go down to open positions, and obviously those are adjusted on the turnover and new hires. If we go down to the leaves of absence, stayed about the same as last month. They're kind of holding steady with about 20 active leaves of absences. No work comp lost hours for December. And then we did have an uptick in missed shifts due to COVID issues. So 72 shifts or roughly 575 hours missed due to COVID type reasons. Do we have any questions?
Brian, may I?
Yeah, go ahead.
I know I've probably asked this before, but I forgot. When we look at the open positions, are you looking at open positions based on if we were fully staffed for our 135 people or whatever we could actually fit?
Correct. That's open positions to budgeted amount, which budgeted amount is fully staffed.
Okay, thank you. And I guess this is the time to ask. We had discussed to make sure that we are taking residents in only if we can staff adequately without mandates and without extra overtime. Are we still managing with this 90? We can still do that?
Correct. Yes, we are.
Have there been any mandates?
If there has been, it has been only due to someone calling in for a shift and having to stay because we can't leave an unattended household, not due to not having enough to schedule.
Oh, hey, that's really good. And finally, stopped coming to work. That would just drive me nuts. These people just don't show up.
Yeah, they just stopped coming.
So a shift comes along and they're not there.
Correct.
That's when the mandate would come through.
With
Um,
commonly with no notice at all. And then when we try to contact them, either their phone's been disconnected or they just don't answer, all sorts of different things. Or even when we mail them, we get it returned back to us, stuff like that.
One final demographic question. Is there any set of demographics, younger, older, all ages that this happens with?
I would say it's all ages. I don't think it's been just one dynamic or demographic. I think recently there's been a handful of younger this time around, but over the course of years, it's been kind of a mixture of every age group.
Okay, well, thank you. I'm just picturing Dave when you were working. If people just didn't show up and didn't call and you couldn't contact them, oh, that would have driven you nuts. But okay, thank you very much. It's just hard to believe.
And Mike, that does drive you nuts. And I don't remember that happening more than a couple of times. But the people that did that weren't my ideal employees. They were probably employees that I hired because I didn't get any applications that were better at the time that I needed somebody. And I don't know if that's what you're seeing. If it would bother me a lot more if you were seeing an employee that you really liked and wanted to keep and hated to lose do that, compared to one that sometimes we have to hire what we can get.
I would say yes, there are a lot of situations that it's someone that there has been previous issues with, or lack of attendance in general. They came and went kind of at on different occasions of sometimes we're late, weren't there, and then eventually just stopped showing up. But there are a handful of occasions that have happened where it's someone that was unexpected.
Chair,
Thank you
can I
very
make
much.
a comment?
Yes.
Yeah, I don't think it's just this facility. I think it's happening across the board on all kinds of jobs. I hear of it all the time, whether it's a grocery store or bank or salon, or you just hear a lot of it.
Yeah.
I don't know what's going through people's minds unless where they're getting their money, but
Yeah, I totally agree with you, Steve. It is happening across the board. I just hate to hear that in a healthcare setting when they're important jobs, no matter what they are. If somebody doesn't show up to work to fix your car, well, that's not the end of the world. But if somebody doesn't show up to take care of someone that needs help, that is pretty important.
Any other questions?
I have a comment. There isn't no way of putting anything in a contract that they have to give you a 2-week notice or anything in a.
No,
Yeah.
Wisconsin is an at-will state, so the only thing with the 2-week notice, it can be policy that it would make them quote unrehirable kind of thing. Basically, it would be something that we would look at if they reapplied for a job. But it's an at-will state, so we can't have them have a contract that requires a 2-week notice. It's in the handbook that we would prefer a 2-week notice, but we can't have them sign a contract requiring it.
Okay,
Right, thanks, Chris. And we'll move on to the resident referral report. So this looks similar to last month. We did have a few more admissions this month. We did have a couple people come and go. We had a few people hospitalized, so that's why that number is higher, as well as we did start admitting to some of our empty beds in the open households. So we did not open Fireside or Arrowhead, but we did try to maintain close to that 90 census, and we did get up to, I believe, 96 was our highest, which was manageable with the staffing that we had. So we started out with 90 residents. We had 140 referrals. That is the highest number I believe we've ever had. It's just to the point that nowhere is accepting, as well as across the country. So we're getting referrals from Illinois. I believe there's been some. We're getting referrals from Rochester, all over the place, just trying to find somewhere for people to go. It's twofold that people aren't accepting. It's partially due to staffing, as well as COVID outbreaks. So as COVID ramps up again, and we're seeing it here as well, that you can't admit if you have COVID positive staff for 14 days in the household that they worked in. So just as we had enough staff, because we did actually, based from our agency staff, as well as we did hire some new staff in between here that may actually hit on the January report, that we were potentially at the point that we looked at, well, maybe we could admit more, we can figure this out. But then we had every single household on campus have a COVID outbreak. And then we weren't able to admit as well. So, and that's not just us. We do report to a statewide resource center kind of thing that helps hospitals know who is and isn't accepting, so we can see in our region who is and isn't accepting. And I think it was last week or the week before, I don't believe there was a single nursing home listed as accepting residents. And if there were, it was like 1 or 2 open beds kind of thing. So it's a really big crisis for the hospital systems that are just getting backlogged because we can't accept. So that's kind of an ongoing thing. So we did have 13 admitted. Like I said, a lot of that was people going to the hospital and coming back to us. So those you can count as admits. In our system, they're called readmits, but it is an admit. At the end of the month, we had 91 residents in-house. 3 established residents were at the hospital at that time though. So really our census was 94 was the residents that we had beds spoken for, because the 3 in the hospital were going to return to us at the beginning of the month of January.
and did they, Carmen?
Yes. Yep. So we will accept people back. And even if we do have a COVID outbreak, that is the only exception, is that they can come back to us. So we don't, if we're in a COVID outbreak situation, we can't accept new admissions, but if there's someone that already was our resident, we can accept them back, so they can come back. They don't, the regulations don't require us to have them then stay in the hospital or go somewhere else since they are already our resident. We did have 2 deaths in the month, which is a low number for us, which is good. And we had 0 people discharged home. That's primarily because we didn't have a Medicare census. So people that aren't coming for short term, no one's really discharging home. Our referral sources were the same as normal for the big ones, for the ones we get a lot of, but we did have a couple of other outliers that come from all over the place as well. Is there any questions on the referral report at all?
I guess I have one. You mentioned that you didn't have any Medicare discharges. Is that because of staffing? We don't have any, or because the hospitals aren't doing any?
That's due to our admission status. So that staffing component as well as the COVID outbreaks. So when we closed down Fireside and Arrowhead, those were our 2 short-term rehab households. We will admit other people to the other households for short-term rehab, but when we weren't accepting referrals, people weren't going home. So we did accept a few short-term rehab referrals in December, but they were still in-house as of December 31st. So we will have some discharges in January, so in our next meeting, because they were just here over that time frame. So when we started to admit, we will have some going home on next month's report. But from November's report into December, we didn't have really any admissions that were short-term rehab. So before the 31st of December, no one had gone home because they were still here if they were a short-term person.
Okay, thank you.
Any other questions?
Steve, if you're talking, you're muted.
So once some of the residents go home, if there's still an outbreak that you cannot accept anymore?
Into the specific household. So if there's a household that is currently in an outbreak status, then they can't be admitted to that household. So Deerview, for example, in Central, if they're in an outbreak, we can't accept there, but we could accept in Tender Hearth if they aren't in an outbreak. So it just depends on where that was. So right now we only have a few that are currently still in their 14 days for their outbreak. But at one point this month, well, in January, actually, so not in December, which this report is from, we actually had all 7 of the open households in an outbreak at the same time.
So an outbreak referring to how many?
So an outbreak is anytime a single staff or resident tests positive. So in healthcare settings, ours is a little bit stricter than general public. So general public, if there's 2 people that work at a certain place, that then is looked at as an outbreak by public health because it shows spread. In nursing homes, it's if a single person tests positive. So even if if they had been in the facility during their infectious window, so 2 days prior to symptoms or positive test. So if a staff member came in on Monday or called in on Monday that they had a sore throat, they test positive and they had been here on Saturday, then that puts whatever house they worked in into an outbreak.
Okay, thank you.
Mm-hmm. Any other questions for referrals? All right, then I'll give it over to Scott for facilities report.
Good morning, everyone.
Morning, Scott.
Well, I guess I'll start out with our excitement of a flood that we had on January 4th, early in the morning. Staff got contacted about our sprinkler system having a trouble in it. Once that was investigated, found that a valve on a sprinkler system test line in a mechanical room in Arrowhead had cracked from freezing. Luckily, Arrowhead has no residents in it. So once that was discovered, facility staff was called, Carmen was called, and the staff came in. They got it shut down, investigated it, found out that there was also a 90 copper 90 on a domestic water line that had cracked. They got everything shut down. They isolated it so that there was no more water flooding. Started cleaning up the water. Majority of the water was in the custodial mechanical room. There is a floor drain in there, but it did spread out and did flood hallways and some of the rooms there. They did a great job of getting things taken care of, working with Carmen. We got a hold of Ahern to come in. The company that works on the sprinkler system came in, repaired the valve. It was a relatively simple fix for them. Our facility staff repaired the copper 90 on the domestic water. It was back up and running fairly shortly. I think the sprinkler system was back into service in the morning of that day, Carmen.
So it went out of service about 3 in the morning, and then we were put back into service about 12:15, so a little after noon.
Okay, so
That was the time frame we were on fire watch for.
Yes, so all in all, it got put back together pretty quickly. Things got dried out. Like I said, the water got sucked up, cleaned up. Fairly minor damage on it. Ceiling tiles in the custodial room all got damaged. Those had to have to be replaced. In the mechanical room where the leak was from the sprinkler system, there was some drywall damage that facilities can repair this damage, get things taken care of there. All in all, it wasn't bad, but it was a lot better situation than the flood that we had in the government center the day before. Aside from that, from our federal look back survey, there was a question there from the engineer about being certified for fire door inspections. So I had Josh went through a NFPA training to get certified for fire door inspections. So he's now certified. So that marks another thing off our list of things that we have to correct for the federal look back survey. He got that taken care of. So now he can check the fire doors, inspect them, make sure that they're looking good, and that'll satisfy, it'll satisfy the state for sure and federal. Aside from that, it's the usual of looking at the heat system, keeping that going. We've done some repairs on boilers, keep those good, got those going for backup, keeping the geoloop system warmed up in the building, keep things going smoothly. Otherwise, working on work orders and keeping everything running. Does anyone have any questions?
I do, Scott. I'm kind of wondering how them lines would have froze. You got the heat turned down in there? I know stagnant water freezes quicker than moving water, but.
So the pipes were in a custodial room, and then back from there is mechanical room. The mechanical room, the heat in there is off of the water heater for that household. And at that time, that water heater was down.
Oh.
So there wasn't any heat coming off of that. The sprinkler system test line is on an exterior wall. Ended up getting cold enough to freeze that. That is still water in that sprinkler system. So that most likely what froze it. Also the copper 90 with no water being used down in that household, there's no flow there. It got cold enough where it did crack. We got things going now, so that is warmed up in there. Things are looking better, so we're going to prevent that from ever happening again.
Okay. I was just wondering, kind of curious.
Yeah, I figured that'd be a question as to what caused it, for sure.
Yeah. Yeah. Thanks.
Thank you.
Any other questions for Scott at all? Right. The only thing I will add to the environmental facilities report is a little bit more of an update about the survey from the federal survey. We did, as I think I mentioned last month, we did IDR, so informal dispute resolution, to try to fight one of the citations. We have yet to hear back. They do have 45 days to do that, and it's been just a month. So hopefully in the next week or so, we'll hear back from them. In the meantime, we did look into the process of what we have to do to repair that. So I have been working with the federal surveyors about an extension for that, as technically speaking, if we lose the IDR process, then we would have to have that fixed by, it's the first week in February, which would not be doable without pre-ordering the part, which has to be custom made, which then we would acquire the cost of that. So if we win the IDR, we don't want to have to pay for that. So I'm working with them for an extension on fixing that due to the IDR process, which after speaking with the state surveyor about it is a frequent thing that they work with. So hopefully that will occur. All right, up next, talking about surveys was Wes Complaint Survey. So last week we received a complaint. Oh, sorry, did someone have a question?
I have a question for Scott. I was wondering if he had heard any more about cost on the sign. If they had done any more on that.
The sign for out by the highway?
Right.
No, I have not gotten any more information back on that.
Okay, thank you.
Yep.
So as I was saying, we received a Wes Complaint Survey. In the past, we've had complaint surveys. It basically is normally one surveyor comes to the building. They're off cycle from our annual surveys, and they're really only there to look at what the complaint was about. So depending on what the problem was or what they received a complaint about, they would only look at those specific things instead of doing a full inspection. And it is typically only a day-long survey. This time ours got extended because they needed information that we did not have from the hospital system. Since the person that the complaint was about had been discharged to the hospital. This person is no longer with us, so we do not have access to their hospital records anymore since they're not our resident anymore. So they had to do a formal, the state surveyors had to do a formal request for information from the hospital, which takes time. So we are still waiting for the results of that survey. They were only in our building for a day. And then they will be exiting via phone from us once they get the information from the hospital. As of yet, we have not heard any news about it. So typically in these processes, no news is good news, but we will keep you informed next month of what the results are of that. Typically, I would expect a request from Mayo to take a couple of weeks. So hopefully by next meeting, we have the information. Any questions about the Wes Complaint Survey? All right, so move on to COVID-19 updates. We've already talked about this a little bit, but we have seen an increase in COVID cases in staff. We actually had, I think this is 2 weeks ago now, we had a day that we had 7 new COVID cases in a day. 6 were staff and 1 was a resident. That was our highest number of COVID cases in a day since the beginning of the pandemic. So we are seeing an increase in cases, which coincides with everything that's going on in the community as well. Luckily, we haven't had any of our staff be extremely ill, just the lighter symptoms that the majority of people experience, but it does put a strain on our system for scheduling as well as the outbreak status and the extra precautions that have to be taken when that occurs, and just the process of reporting and putting the whole system into action also does take a significant amount of time as well. The one resident case that we do have, this resident actually had a visitor that tested positive right after they were here to visit. So we had the individual on isolation immediately after we found out about that. So the visitor was here on a Friday. We were called on Tuesday that he tested positive, but started having symptoms on Saturday afternoon. So we put that resident into isolation at that time, as the resident was not vaccinated. And then we found out by Wednesday that that resident had tested positive. So that person is still currently on isolation, but will be coming out shortly and is doing okay. So we didn't have any other residents test positive from that outbreak. And it was an isolated case that we can pinpoint back to a visitor. So it's another avenue that we're doing what we should be doing with masking and infection control, and that our process for stopping the spread does work. So it's all going well with that.
Good.
The other COVID situation that I'm sure you're all aware of is the vaccine mandate. So as I believe we talked a little bit about this last month too, but as we are one of the states that was not part of the continued litigation, our dates are next week. It's actually a week from today. The 27th is the date for the first dose. And then a month from then is the second dose. Based on what time the state or what day the states or part of the litigation is, which day the state has to comply by. So our group, the fifth, I think it's 26 states. We're not part of the litigation. We have the first states, and then the states that were part of it, with the exception of Texas, have a different set of dates. And then Texas, as of yesterday, the mandate was put through for CMS providers. So their dates are even further back, but ours are part of the first states. So we're working through that process. We actually have a vaccine clinic today for staff to receive either the first, second, or booster dose of the vaccine as well.
How is that being received by the employees?
Well, we were fortunate to have the vast majority of our staff be vaccinated already, so that's a benefit. We were very fortunate to have, I believe it was about 70% of our staff were vaccinated at the beginning of the vaccine mandate, which obviously ebbs and flows with people coming and leaving and things like that, but roughly 70%. We have had quite a few people get the vaccine to make it, I believe now we're closer to that 80% that we're kind of waiting for someone to tell them they had to before they were going to do it, kind of thing. We do have quite a few exemption requests and exemption approvals too for the vaccine. So HR has been super helpful with that process. So we've been working through that, but we do still have a handful out there that haven't done either process. As you heard during the employment report, we did have one person that just resigned the second it was mentioned. So it's not been as negative of a response as that we might have anticipated, but there has been some pushback as well, which we expected.
Sure. Are there any other questions for Carmen? Dave?
The example you showed with the person that came in and spread COVID to one of the residents. And they showed symptoms on Saturday, and they didn't get their test back till Tuesday to be able to let you know. Is there, with our testing that we have available there, in a case like that, would we be able to test somebody that isn't an employee? Or I don't know, I'm just throwing that out there because it seems like wherever I go, a lot, I don't know if it's just us older people, but we talk about where would you go to get a test if you had to?
Right.
And it just, you know, I look at the email from Carmen or from KT, excuse me, and you can go to Lake Hallie or you can go to Jackson County. It doesn't ever seem like you can go to Dunn County. You can call your providers, but my experience with trying to get into a clinic lately is difficult at best. And I haven't tried one of the pharmacies, so I don't have the experience there, but I'm just wondering, we have that capability. Can you use that at all for people that are visiting if they wanted to get tested? They'll make it optional or something?
So two things with that. This individual actually didn't choose to go in and get tested until Monday. So that was just their personal choice that they waited and then decided, oh, I was at the nursing home, I should probably go get tested, is what they told us. So then they got their results back within 24 hours of when they got tested. We tell all of our employees if they have symptoms to go to Mayo. They've been the fastest turnaround time that we have seen. I know Marshfield has a pretty quick turnaround time as well. We actually do not at this time have anybody with symptoms tested here unless it's a resident. So if a staff member has symptoms, we don't test them here. We tell them to go somewhere else to get tested because we don't want someone with symptoms in the building. So if they come into the building, if they have contact with anybody while they're here, we don't have the setup to do like what Mayo does with specific procedure rooms and things like that to do testing. They would have to enter the facility and potentially expose other people based on our setup. So we actually don't test symptomatic people. So our testing here is primarily outbreak testing. So if someone's been exposed, or just regular routine testing for unvaccinated staff. So it's an option we could do, but it would just add some added risk to COVID-19 being brought into the building if people are symptomatic.
Well, I was thinking, I guess I wasn't as clear to my thinking, is if somebody's coming to visit somebody else, like if I was coming to visit my mother when she was there a few years ago, and you had a sign at the door that I could get tested and I could find out if I'm negative in 15 minutes, I might take that option. Now I realize that you'd have to have probably a room set aside to do it, but there'd be minimal contact in the facility because I wouldn't be walking around the whole facility if I found out I was positive, you know. And I guess that's what I'm saying is that something we could consider doing as an option for visitors coming in?
We could. The only part of that that's a little bit challenging is the staff to perform the test as well as the reporting process. So all of those 15-minute point of care or rapid tests have to be reported to the state of Wisconsin. So every time those are done, they have to be reported within 24 hours of them being done. So that would require, currently there's only 3 of us that have access to report those. It would require someone doing that every day because we can't restrict visitors to a certain time of day or day. So if they're coming in the building on Friday evening at 6 p.m., someone would have to report that by Saturday at 6 p.m. So it would be an option. It would just be an added time for staff situation, or have someone that could be performing the tests here at all times.
Well, I realized that it would take some staff time, but I was thinking that little prevention might save staff time, and also.
Yeah.
If we could keep from having an outbreak. It was just a thought, something I was thinking of.
Yeah,
David,
sorry. I do know that there are some facilities that have that as a thing when everyone, basically almost all visitors are asked to be tested before coming in. the only issue with that that's a little bit difficult with our setup is I believe those are primarily in places that have one entrance. So then there's always someone at the front desk. That person is the one doing the swabs, things like that, versus our setup where there's 10 different entrances to get to 9 households and then the front entrance. So
And that's why I was thinking to put a sign there that it's optional and you could direct them to the front desk in that one building if they wanted to do that. I would think that you would get a few would be concerned to protect their loved ones before they went and saw them. I was just thinking it just might prevent an outbreak. That's all.
And Dave, I have to agree with you, but I also think that the people coming in to visit, they should be responsible enough to get a test prior to coming in, especially if they've had anything at all, any symptoms. But
I agree with you there, Brian, but as I started out before, where do you go get a test? Do you know where to go get a test?
Most of the providers are given tests, Dave. Most of the providers like Mayo and Marshfield today are giving tests for that. I know my daughter teaches in Eau Claire and she has 2 kids in daycare. And I believe my granddaughter has been tested probably 5 times in the last month because she's exposed or whatever to another kid in school. And she just goes to the provider and boom, they're tested. But it's a PCR test. So.
And I didn't know that.
Yeah.
I mean, you know,
Okay.
and I think a lot of people out there, well, I know a lot of people out there in the same boat as I am. Where do you go to get tested if you want to get tested?
Yeah.
And I don't really have, I don't have a mother or a father in a rest home where I'm concerned of that. I mean, a lot of the people that I deal with are younger than me, and I'm not concerned about giving them, and frankly, we don't go anyplace either. We try not to. But I'm just saying that a lot of people don't know where to go, and
I understand.
this might help.
Steve?
Yeah, just as a.
Yes,
Go ahead,
yeah.
Steve.
How many visitors maybe come 3-4 times a week? That would be hard to be, maybe for them to be tested that many times. Is that a problem with?
There's a few people that are here daily. It's hit or miss. We have some people that like if someone's spouse is here, most of the time those people are here daily. Versus if it's their parent, maybe they're here once a week. It kind of just depends on the situation. But we do have people that are here more than just once or twice a week.
Mike?
Just as a follow-up to what Dave is saying, yeah, I can understand. I guess it's a matter of the health department getting the information out, but CVS, Walgreens, you just go out and get a test, you sign up. Stout is extremely easy. You get the quick test, and then if it's positive, you can get the long test. You can get them in the mail for free now. There's just multiple ways of getting them, and it just needs to be put out there a little bit. Because Dave, you're really up on things, and if you don't know, I'm sure a lot of people don't. So, but there's just so many ways that they can get tests free. So I like free.
Yeah, my wife signed up for the free ones. It's going to take 4 to 6 weeks to get the email we got back.
Yeah.
So we'll probably be past the peak by the time we get those free tests. And as far as Stout, I've heard that you can go to Stout, but I haven't seen any information about where you go to Stout to get that. And you're right.
Yeah,
maybe we should be getting that information out more to people.
Stout's really easy. It's a big parking lot. It's at the Fayette building and signs everywhere. So if people aren't afraid of going down to Stout, which some people are a little leery, it's very easy. Same thing with the mail. I was in there for something else the other day, and just people walk in and get tested.
Yeah.
So, but yeah, it's hard to know. Thanks.
Good conversation.
Does anyone have any other questions for me about anything?
Just you're doing a great job. Keep it up, Mrs. Meyer.
Well, thank you.
Okay,
Yes,
thank you, Carmen. for
Great
your
job
report.
with such hard times.
You are. Yeah. Okay, we'll go into considerations for actions. Review of vouchers. Does anybody have any questions on the vouchers? And seeing none, we'll go into Jane's financial report. Good morning, Jane.
Good morning, everybody. Paul, would we like to introduce Beata to the group first?
If I could get my camera to turn on, that'd be wonderful, but it's ignoring my clicks. I guess it doesn't want to show anything that ugly. I think most of you have been introduced to Beata Haug, our new CFO, last night, if not before. She's working her way in and doing a fine job so far in the short amount of time she's been with us. She's really dove into the deep part of the pool. I know she's been working very closely with Jane on all things NDC. But Beata, is there anything in particular you want to add?
Yes, well, first I want to say thank you. Thank you for inviting me to this meeting and meet you all. As Mr. Miller mentioned, some of you I've already met in various meetings. I just kind of want to touch base a little bit about my background. I'm very passionate, if anything, about process improvement, overseeing policies and procedures and best practices, especially in the government sector. I've been around in multiple counties and we all have our own unique challenges. So one item I'm passionate about is to look at those opportunities, recognize those opportunities, recognize where we have the gaps, and start that as a beginning of how we can improve things to get us in a better position, to set us up for success. And I've worked with Jane in the past. She's extremely dedicated to the nursing home. I worked at St. Croix County and she was there with me, and her and I kind of had the oversight, the financial component. So I'm somewhat familiar, but not as much as Jane, but she played significant role on getting that revenue in and keep down those write-offs. So she's doing the same thing over here. She's very dedicated. So it's an honor to be part of this great team. So when I accepted this position, I felt confident that I knew where I was going and who I'll be working with. So thank you for this opportunity. And I'm looking forward to some of those process improvements so that we can position ourselves in a bright future. So thank you.
Beata is much too generous, but I did enjoy working with her and will enjoy working with her again here. So thank you. Back to the packet. So I produced the campus census report, and as you see, the Medicaid, the whole census is down for the year. Veterans contract seems to be really helping us out. I know it dips but it seems to be almost holding its own. Those veteran contracts are one per county, so we're lucky to have that. And we've been doing well with getting paid from them. So just a little plug for the veterans contract that we have. Any questions on the census report with the bar chart? The aging report does not look normal. The bottom number is fine. The 909,624 is good. It reflects our lower census and also good collections this year. The awkward part is when I did the retro change on our Medicaid processing within our matrix software, it created these negatives. It unposted in one month and reposted in another month. And my question to the board is, would you like to see me play with some different formats so we can get some more rational numbers in these spots?
Yes.
Okay,
I would personally.
because they really don't reflect the aging, they reflect when we did some transactions in the background. So, okay, I will work on some different formats for the next meeting. Any other questions on the aging? Okay. The pool staff report for the year is not complete. We are still posting invoices to the December as they come in because it's only middle of January. Not so much anymore. I did run this report a little bit later in the month. So it should be fairly accurate, but like I said, it's not audit proof. It's not complete. So don't use it for a guaranteed number when you're comparing to other years, is my suggestion. The CNA, if you look at the very bottom, the CNA line is the one that will reflect Carmen's staffing issues. The total year-to-date is $1.2 million. The total year-to-date last year was 1.19. It's so, I mean, it's close, but our census has been so far down that you'd think all the staffing numbers would be down, but they're not. So our cost per resident in the end, the 1.7 versus the 2.0 on the next line down, show a little better number, but I think with the per resident cost of staffing is going to go up when you do those numbers. So it is expensive. There's not enough staff, and we've known that. So this is the numbers that back that up, that there is a staffing shortage. Any questions on the pool staff?
Hi, Mr. Chair, if I may.
Sure, David, go ahead.
You know, earlier in the meeting, we heard that we lost one CNA to American Lutheran Home, I believe is what that meant, for higher pay. And looking at these numbers, really the only, I mean, CNA is where we really should be concentrating our efforts to get our own people. And maybe that, you know, I've talked before about paying a little bit more and trying to keep our people and trying to entice more. Maybe we should just be looking at the CNA help. And I know at one time we've heard that CNAs that we pay more than other places, but yet we lost one to American Lutheran Home this last month. I think that's what that meant, ALH.
That is what that meant. That was a self-reported number, and she had requested extremely high wage from us, which we vetted, which would have costed her out of our CNAs that had been here for 30 years. So that was a self-reported number that ALH had offered her. So we're not 100% sure on that one.
Right. Okay. I understand that. Sometimes you can't believe what you're told all the time by employees. But the bottom line is we're paying an awful lot of money for pool help from CNAs. And maybe if we were paying higher than the other nursing homes in the area, maybe that number would go down. And maybe we should, I know I've asked you to look at the RNs and you did. I don't remember if you look specifically at the CNAs, but maybe we should concentrate on that. That's all I guess it's pretty evident to me that we've got a problem with CNA help. We need more.
CNAs is definitely the greatest shortage. I know in the past when we were talking about wages, our RN wages were further off of our competitors. Comparatively speaking, our CNA wages have been at or above our competitors for the most part. So that's why the wages we focused on our end, since they were drastically below what we were hearing from going to Mayo and whatnot. But that is, I agree, our CNAs is we need more of them and we lose them easier, as well as you need 2 to 4 CNAs for every nurse for our staffing ratio. So you just need more bodies in general too.
And we thought that adding the homemakers would help with that, but the truth of the matter, maybe you think it's helped, but just looking at the numbers every month and seeing how many CNAs we lose, I don't know that that's helped a lot. Maybe it has. I'm sure it has. I'm not questioning that because you're the expert, but I just think we need to concentrate on getting more CNAs and keeping them. And I don't know, maybe, I don't know what to do, but you're the expert. Maybe you can come up with something.
I have to agree with you, Dave.
That definitely is our biggest focus is the CNAs right now, as that is our biggest shortfall in staffing. So that is our focus, is to hire more and keep more as well. Unfortunately, there's just not as many out there as everybody needs to.
Mike? You had a question?
Yeah, a couple of questions. Thank you, Brian. So how about the CNA class? You're able to offer that now? You explained that earlier. Could you?
We do not have it yet. We did work with a program with the state was going to do some sort of online CNA class thing, and that did not come to fruition. So now we're kind of back to base one on that, but that is something that we are working on.
So you have to get your own curriculum and teacher, is that correct?
Yes.
Okay, you can steal a curriculum though from somewhere pretty easily, I would assume.
Yes, that is our
I'm
hope.
sorry, you can
Instead of
borrow,
writing it,
borrow.
borrow. That is our hope. We had a nurse that had started here, or was going to start here, and then that had previously taught CNA classes at a different facility. And our plan was to utilize her knowledge of curriculum to build one, and then she ended up not coming here. So we will be looking at other options for curriculum at this time, because we do have to
Okay,
have a
and
specific curriculum.
in relation to what Dave asked earlier, I remember last time you talked about comparison of number of residents and costs,
Mhm.
and you gave us some great numbers. Did you send that out to us? That information out to us?
I don't recall, but if I did, I can resend it, and if I didn't, I can send it.
Yeah, I probably lost it. Could you resend it again? Thank you.
I might have forgotten to. So if I forgot, I'll send it out right after the meeting.
You've done a lot of great comparisons. It's we just need to keep track of them ourselves here.
Maybe if we had a nurse and a teacher, that professional team that is retired could work on a curriculum in their spare time.
But good idea, Dave. Yeah.
Well, Dave, that's not so far fetched. I think there are a couple people that could do that.
Might help.
Yeah. Any other questions on that subject? If not, go ahead, Jean.
Okay, then we'll move to the profit and loss statement, the income statement, which again is not final. It is preliminary. And as we keep posting numbers and invoices come in for December services, we will keep posting those to the expenses. But the revenue should be fairly close. We look at the year-to-date revenues and the budget variances. If you go to the private pay line, we're short $1 million in private pay people. So that's where we're losing. And also we are short in the Medicare A category. And that's almost $2 million that we're off per budget, to budget. There are many more Medicaid people that more than that we had budgeted. But the net result of that is only the 260,000 in additional revenue. With a caveat that if you go down to that supplemental payment of $522,000, that is part of the Medicaid monies. So that increased from what we were expecting by $522,000. That's a lot of money in the supplemental payment that we were not expecting. So that's based.
You just turned off,
You're
Jane.
muted.
Okay, I don't know how that happened. I didn't move. Where did we leave off? Did we catch the supplemental payment?
We were on that, yes.
Okay, so that is based on the number of Medicaid beds from the previous year that we've built. So it's okay. That's a good number. And then we did also post the COVID reimbursement for the wage increase or the bonus payments. That's that 445 in there, and some miscellaneous. So in the end, we're only off budget by $744,000. Our actuals are 13.1 and our budget was 13.9, which is as a percentage pretty close.
You're muted again.
Jane.
I'm thinking my bandwidth is maybe having a problem. Sorry about that. The COVID expenses will net out with that COVID reimbursement up at the top. So any questions on the revenues?
I've got one on the private pay. Is there any background before they are admitted into that as far as their ability to pay before they're admitted? Carmen, maybe you could.
So we do ask for a month payment up front. So it's basically advance pay. And then they're billed every month up front. So for the month, but we don't do like a check on their overall finances. So, and we technically speaking, I know based on like rehab beds and memory care beds and things like that, different people can be admitted to different places at different times. But if they have a payer source, whether it be Medicaid, Medicare, private pay, we don't use that as a determining factor on if we admit them or not, as long as they have a payer source. If there's someone that comes in and they don't pay privately or can't pay privately and haven't applied for Medicaid or don't have a Medicare benefit from a hospital stay, that would be someone that we'd say doesn't have a payer source. But if they can start paying private pay, eventually most people transition into Medicaid, as it's not very common that someone has the finances to support private pay long-term care for very long. It's extremely expensive, and there's just not very many people that can afford it anymore. And as we see this trend going on, I truly think it's going to be more and more people that don't have the finances, as people just don't save like they used to. So it's kind of a trend that we're seeing, and I would expect to continue.
Do you help them transition from private to Medicaid?
Yep.
You do.
So we typically refer them to the ADRC. So the
Okay.
ADRC helps with that process. We typically find out that someone's needing to apply for Medicaid if they stop paying us, is a lot of times the occurrence, but other times it's they know that they're not going to have enough money. Sometimes people will ask us questions about it, so we typically refer them to the ADRC, and that's one of the services that they offer, is helping with that process.
Okay. The reason I ask is, a few months ago, I noticed that in the local newspaper that a nursing home, I won't say which one it was, sued one of their residents for non-pay. And I have never seen that in the paper before. And I was just curious about it. So didn't know why that would ever happen. I don't understand that, but I don't know.
that's a bit of an extreme situation. It probably was, they owed a lot of money. But typically there's other steps that can be taken prior to that scenario, but that would be something that well, it always starts with a 30-day discharge notice, things like that, which we try to avoid those things at all costs because we want to work with people. I mean, they need health care. We don't really like kicking people out.
Oh, I understand. I understand.
So, yeah, so it's always a touchy situation. And commonly our residents, it's not dealing with them, it's dealing with families, or if they don't have families locally, that's always something different too, because in most cases, it's someone else dealing with the finances and not the residents. That's a whole nother aspect of that as well. So sometimes the ADRC gets involved in that for other reasons too, if the person is not fit to handle the money as well.
Okay, thank you.
And in those
Chair?
cases, they would most likely feel that the person had the money to pay, otherwise they wouldn't have gone down that route.
Oh, okay, okay. Okay, Dave?
Yes, the 522, 435 for supplemental payment, was that the back pay in the Medicaid from after they raised it? Okay, that's a different payment.
It's a different pot of money that the state has set aside for what county nursing homes can receive. If there's fewer county nursing homes, our portion of that bucket may increase over
Okay.
time, and it's a per day rate. So they had extra money this year, and our cost reports include as much expense as we can put on there, even though we're over the caps. It's like a tax form where you have more expense, but you can only claim up to a cap. If we include all the expenses, then this is where we can capture that.
All right. And then my other question is, I know we got a Medicaid increase at a certain point this last year. Was that about the middle of the year? If I remember right, or?
It went back to July.
Okay, so next year, we could probably think that the Medicaid reimbursement may be, that those numbers may be higher just because we're gonna have a full year of that higher rate. And there was, in that bill that when they gave us that raise, is there another raise coming for 22, or is that for 23? Seems like they were gonna give us two. In the bill that the state passed, there was gonna be two raises, or am I wrong with that?
I haven't heard about that. But we budgeted an extra 10% on the Medicaid rates, so it won't be that far off. We did budget higher already to accommodate. We knew this was coming somewhere between 8 and 14%, so we budgeted at 10.
All right, thank you.
There, if I might add as well, there is also a change with how Medicaid is doing their process for billing. They're transitioning to PDPM, which you might remember from a few years ago is when Medicare changed their billing process and their coding process and things like that. So that might also affect our rates. We won't see that until the first review after, because that started at January 1, but that could also change Medicaid rates. So it's a little bit difficult to project what we might be seeing from that as well.
So are you expecting that change to be a positive for us, or it could be a negative?
We don't know yet. My guess would be a positive. We did have positive increase for our Medicare when PDPM went into effect, but we can't say for sure. It basically is, the goal is to have nursing homes have a more accurate payment for what they're actually doing instead of having it as like ballooned into generic things. It's going to be more specific for if someone's on this, you get this versus that. It's still an averaged out thing like it is now, but it's supposed to be more accurate of the care that you're providing. So hopefully it actually bumps us up.
And on that note, yes, every Medicaid resident will get their own rate based on their scoring with the MDS team. And the software programs, I was with a leading age group yesterday. There is no software that is ready to bill for this yet, and it's rolled out January 1st. So we're not behind in that one. But our software was updated yesterday and we're working to do testing on that. It's a big, big change as far as billing. And Medicaid has a test site, so we can work on that. Claims that will go in February for January will be our test of really where are we at the end of the month. So we'll keep you posted on how that works. Looking forward to that whole new change.
I bet you are.
Yeah. So that's the revenues. 13,000 of the miscellaneous reflects the donations for the van that Carmen's team has been working on, raising money. So when that does have to be recorded in our statements, but that is held out for their donation account. On to the expenses. They're not that far off. They reflect what we've done. There's been a couple payouts in staff that retired in social services, in life enhancement and dietary. Dietary cost has gone up tremendously this year, although we're going to use some of that expense and offset it with COVID dollars, which I'll get to in a minute, the COVID dollars. We haven't had a lot of write-offs, but they are embedded in the administration costs. So it's still under budget, and administration is pretty much salaries again. So we're doing okay there. If we go down to the bottom, let's see, let's do senior meals. They continue to increase in numbers and increase in the revenue because we're getting a fair price from ADRC for the meals that we provide. Therapies are lower because, of course, we have fewer people. So that's a direct reflection of census. When we come down to the bottom, the net income and loss, the actual income loss is a positive of 164,000. It's off according to budget, but it's still a number not in parentheses, so that's a good thing. And then it does, that 164 incorporates 10 months worth of depreciation that has been posted to the computer system. So that's where those numbers are. And then I added in at the bottom 112,000 of the other 2 months of anticipated depreciation posting. Subtract that, and we still have a number that's in the black, the 51,000. So kudos to the staff for keeping that in line. That's where we ended up tentatively. If I could, and especially so Beata is up to date a little bit too, the annual depreciation is $676,000 approximately. That is not a cash expense. So if you're looking at this report as a cash expense, keep that in mind, that's being put away to offset for future expenses. COVID dollars would be next if we're ready to move on to that.
Sure.
Okay. We have received phase 4 provider relief funds. We had no idea, they talked about phase 4. I applied for it, spent a lot of time on those calculations. They broke the phase 4 into rural and general allotments. We received $576,000 for the rural portion, and we received $80,000 for the general award, totaling $656,000. Those dollars need to be used up by the end of 2022. So a little bit of those numbers were based on behavioral health and mental health lost revenues. But most of it, the majority of it belongs to NDC. So we can offset lost revenues, provide other COVID relief for COVID's expenses, and make it through 2022 without a loss, I believe. After that, 2023, I haven't heard any money would be coming from the federal government. But that's the future money. So we were glad to get that.
That's very good news. Very good news.
Yeah.
If I may, Mr. Chairman,
Yes, Paul.
the one caution, and I think everybody knows this, COVID money is helping us float this enterprise. When it goes away, we've simply got to, I think, keep a honest picture in front of ourselves and in front of our constituents, the citizens, about the financial reality, because it's easy to get hidden. I'm very pleased that we've received the COVID money. I'd much rather receive that than suffer a loss. But 2023 could be a wake-up call if that money cuts off and we're back to actual expenses versus actual revenues. So I think this probably goes without saying, and I apologize if it does, but it's a good caution to keep in mind.
Absolutely.
Can I add one thing on that note as well?
Sure, Carmen.
And I agree with Paul that it does add some different aspects that won't be there most likely in the future, but also just keep in mind that all of those numbers are attached to expenses or losses because of COVID. So hopefully, if we are no longer getting COVID money, we'll also no longer be incurring those COVID expenses or having the amount of lost revenue because of COVID. So those are also attached to other things. So hopefully, if we aren't getting the money, it also means we're not incurring those expenses.
And the final part on that, again, Carmen and I agree, is that it puts us back into the reality of staffing versus, how much staff we can get in, how many beds can we fill? We know we could fill them all. We don't have the staff. The COVID will wash expenses versus revenues. That problem is going to continue to be one we're going to struggle with.
Yeah. And if I may, on this expense report, any COVID money that is on here has expenses to equal that. Correct. So yeah. And those would have been expenses that we wouldn't have had if we didn't have COVID.
Or above and
Absolutely.
beyond.
Yep.
Mhm.
Mhm.
Yes.
Like, for example, the food, we'd still have food, but the cost of food would not have gone up as significantly. So we're acquiring the extra cost is used as a COVID expense.
Okay. And then one other question. You talked about depreciation, and that's in the property ownership line, correct?
It is in the, yes, property
Okay.
ownership. Mhm.
So,
Yep.
so I know you said year to date 600 and some thousand, but I missed so year to date, that was 631,000 for.
Yep. And if we add the 112 that we're expecting to post to that would put us a little bit over budget in property and ownership use.
Oh, I see. We have to add that to the year to date column.
Yes, yes.
All right, so it's actually 740,000,
Yes.
which I don't want to sound a lot like Elton, but he always used to point out that isn't a cash expense that we have. It's actually money that we have hopefully put away someplace. I would guess in the general fund to pay for expenses coming up down the road.
Facilities,
Like more, yeah, like more water leaks or whatever.
right.
Or capital expenses. For example, there's new trim that is budgeted for 2022 to be put into each household, one in each building or 3 households total. that money, in theory, on paper, would come out of this depreciation fund, because the depreciation, in theory, should be funding your next capital expenses.
Right.
And is that it isn't just in the general fund, it's in a fund that is held for that specific reason?
On
It's
our,
a
yeah, on our
specified fund?
audit, we have a retained earnings line.
Okay,
And I think technically it's held in the general fund, but the retained earnings would be our portion, or it's a segregated, assigned portion.
yeah,
of the
it wouldn't be
fund.
part of the unassigned general fund, it would be part of this
Assigned.
set aside, yes. Okay, thank you.
Yep, that's where that assigned line in the budget goes, or in the
Right.
audit goes, when you see it in July or August. Yep.
Right.
That concludes my reporting, unless there's other questions.
Anyone have any other questions? I'm hearing none. Thank you, Jane. Is there a motion to approve the financial reports and the vouchers? Supervisor Kinnear moves. Is there a second? Chair Bartlett seconds. Any other questions? Hearing none. All those in favor say aye.
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 Opposed? Carried. So that comes down to adjournment. So as of right now, we are now adjourned. Everyone have a good day. Stay warm.